Hey guys, welcome back to another episode of Luna Unscripted, where we talk about real life, real career paths, clinical insights, and just share the nitty-gritty details of life as a PT. I'm Katie Wiley, one of your hosts.
And I'm Joe Valdez.
And I'm Marcy Arenas.
And today we welcome a very special guest with us who has a host of just wonderful PT knowledge across the board. Jillian, thanks for joining us today.
Of course, happy to be here.
But we'd love to kind of obviously, as you can tell from her background, she's a fellow Luna teammate of ours. But yeah, we'd love to hear maybe what got you interested in physical therapy initially and kind of how your specialty and your path through PT went from there.
Yeah. I feel like it's not the most unsimilar way I became a PT. So I was a gymnast growing up, had a lot of injuries. So I went into college thinking athletic training. And then because I was a diver in college, they're like, you can't do that because you were a winter athlete. So I became a biology major.
I wouldn't have thought about that. Like as an athlete, obviously, the athletic training, that would be difficult.
Yeah. They were like, you need to choose between being a winter athlete and being an athletic training major. And I was like, well, I'm obviously going to choose being an athlete. And so, went biology thinking med school. And then senior year had like a meltdown of like, oh my God, if I wanted to do any kind of surgery, I'm taking a gap year to finish my stuff. I'd be like 32 years old when I was finally attending. Didn't want to do that. So my undergrad, Wingate University had like a newer PT program. And so my advisor had me go talk to the director. And I learned that PT was more than just old people and athletes, and kind of fell in love with the idea of spending more time with all of your patients and getting to really know them and be a big part of their journey. And so I was able to get my stuff together, apply to just where I was going to school already, and got in. So blessed that I didn't have to go through like the crazy process of a bunch of applications.
That's so nice. Yeah. Where did you end up going to school?
It's called Wingate University. It's outside of Charlotte, North Carolina. It's where I went to undergrad and grad school. So it was kind of nice to stay at the same place.
For sure. I had that same experience. It was very nice. And mine was a direct entry program too. So it was like, worry about it. It was, it's really nice.
I love that. I fell in love with the neurologic population in school. I loved that like everything was a puzzle. Not everybody was the same. A lot of my classmates love orthopedics, and I love that for them. I just wanted a little bit different.
You have some of those folks on this conversation right now.
Yeah.
Although I'm with you, I do love like neuro is so complex and wonderful. And like you said, like very much a puzzle to solve all of the complexities and little pieces of it. I think it's so interesting.
Yeah, and that's not to say some orthopedics can't be complicated. It's just sometimes like solving, like I like figuring out, okay, the lesions in this part of the brain, what do we think is going to be impacted, and like seeing if that truly translates. And then after seeing a lot of those things, actually seeing the patterns come in to go. And so then you're able to really educate patients and be able to, when I was a CI or PT students, is really fun to help them find the patterns to really help the patients flourish. And so I was lucky to do a neurologic residency at Ohio Health in Columbus after PT school.
Did you know that's actually, I live in Columbus. So.
Oh, I love that.
Yeah, so I'm very familiar with Ohio Health.
Yeah. COVID hit during my residency.
Oh boy.
So that was a whole whirlwind.
Yeah.
Yeah. And then there was a hiring freeze, of course, when I finished residency. So I couldn't go hospital based. I loved every setting. So that was tough to choose. Ended up in private outpatient in Vegas because I missed the mountains from growing up in Colorado. And so, we kind of went from like orthopedic and built into a neurologic caseload. And again, just helping the locals there really deal with having a neurologic injury or disease, and going through that process is always so fun.
So your neuro experience is mainly in the outpatient type of neuro population.
And inpatient. I always had a PRN job there. And then, I feel like when you're a new clinician, right, and you move to a new city, all of your friends are also physical therapists. And Vegas is a hard city. I loved the outdoors there and things like that, but my best friend's a pelvic PT and she works in Chicago, and so eventually she peer pressured me because I wanted more of a community, so I moved to Chicago, and I've been here ever since.
I do love Chicago. I was just there, what was it, 2 or 3 weekends ago? Someone I grew up with, her and her husband moved out there, and it's just an awesome city. It's so much
It's
fun.
so good. Never thought I'd live in Chicago,
No,
but here we are. We've have roots in the
so
northern
much to
suburbs now.
do. And then again, you have the option of all the suburbs and everything too, if you want to go that route or stay in the heart of it. My friend who I mentioned was kind of in the heart of everything, and it's such a cool lifestyle. Like they have a community garden and this, it's really neat. I love it.
hmm And then when I moved here, I got into research a little bit more and thought, I want to get a PhD because I was single at the time, and what else did I have to do besides work? So I got into a PhD program and started going into academia, more the professor route. And so it was a really cool experience to be full-time assistant professor while pursuing a PhD. But academia is hard. Like when you're a student, you think your professors have this like cush lifestyle.
Yeah.
No, they don't. They
I
really
know some
don't.
things about academia that we don't know. So I've done just a
Yeah.
little bit, not in a PT program, just at a local community college here, just teaching anatomy. So a little different experience, but that I haven't been in like the CAPTA accredited, PT program. So I know there's
Yeah.
extra layers of responsibility and things you have to do for that. So tell us more about that. I don't know a lot about that side
Yeah.
of things.
So
So I'd love to hear more.
obviously you're building courses. That was the fun part, right? You get to like really figure out how you're going to make the knowledge digestible and help your students really get the knowledge so that they can apply it to their patients, not just memorize it. That was something really important for me is like, how do I give them the tools to figure out how to problem solve through this information, not memorize it? Because I know about you guys, but I can't memorize anything. I have to think through it all. That was the
Neuro
fun part.
especially. Yeah.
Yeah. I mean, it's obviously overwhelming. You're like, here's everything, make a course. And you're like, oh God. But that was really fun. And then trying to keep up clinical practice. So I started looking at Luna a little bit when I was a professor because it was a way to like get some hours and like maintain my NCS without having to have like a real PRN job, having to work weekends and holidays and things like that. But there's also like service components. So you need to be on committees, looking into curriculum, and then campus-wide different things of service is like part of there's usually like a percentage in academia. You're a percentage teaching, percentage service, and then also percentage of research. And so there's a certain number of articles you have to publish or the chapters and like trying to get funding. All of that's a lot of pressure on the professors to get all of that stuff done, especially at
Sure.
R1 institutions or things like that. And so that was the pressure I didn't realize probably my professors had when I was in school. So I understand a little bit more why they were stressed out besides like teaching a course or two. And then like students have a lot going on. Since the COVID, they had to go through a lot of things in high school and college, and they're just different students than when we went through. And so it was like, I feel like I wasn't that far out of school, and I had a hard time sometimes trying to understand maybe what the barriers were and things like that. So that was like a nice challenge to put myself in their shoes and trying to figure out what they need to help them be a successful therapist when they go on their clinical rotations, or sometimes supporting them when they're on their clinical rotations, figuring out how to bridge the gap between what their CI is trying to get them to do and what they need. Some of those things are all in the background, I think.
Sure, there's such a difference in just like how students learn now. Like even just thinking back, like I've been
Yes.
out of school for a little while, but not that long. And I'm like, we definitely had hard copy like textbooks and we
Mhm.
were taking notes like handwriting on
hmm
PowerPoint presentations, although there was a select few who would do it on their computer. But for the most part, it was very just like in front of you and you were expected to kind of learn in that way. And it's changed so much. So I'm sure that's, and like you said, let alone the kind of pandemic and how that shifted people's learning strategies. You can only imagine.
I'm
Absolutely.
curious, Lynn, on like your PhD program. Was it one of those where you had a goal to finish it like within like 3 years or 4 years or 5 years, however long, or is it like one of those that you work at your own pace type deal, or how did that kind of work out for you?
Yeah. My mentor is actually a colleague of mine that I had been on a committee with in the Academy of Neurologic PT. And so it was more of a mutual colleague. and I'm gonna put onus on myself. I didn't do the best job trying to like match myself to the category of what I wanted it to. It was more of a convenience what I chose, which all of this could lead to why I no longer wanted to do it and ended up stopping that program. It was they had just started doing a part-time program, but hadn't quite figured out the nuances of what does that mean when somebody can't really be full-time, you're actually faculty, trying to put it all together, and it was just really hard to put it all in. And then along the way, like I found my person. And so my priorities in my own life changed from when I got into the program. I no longer, my overachiever died in the middle of all of this. And so that was ultimately what led, I think, to me no longer pursuing it is just that. But I mean, my mentor did everything they could to try to get me in the lab with everyone to understand the experience. I was writing IRB submissions, helping other people write their papers, all of those things. So I got a lot of really good experience. I just ultimately knew I got like all the courses done. It was like the hard part left. And I was like, I don't think I have the grind left in me
Yeah, that
to
makes
do the hard
sense.
part.
And so yeah, those part-time programs are. It's nice to have that flexibility with that. I'm sure your mentor has a lot to do with like how it's structured and whatnot.
Yes.
Um, but it sounds like a lot, so I don't blame you.
Yeah, no, I think like there's probably going to be more and more of an emergence of that part-time program coming through because obviously there's with so many PT programs coming up, there's more of a need for those terminal academic degrees to keep
Right.
CAPT accredited
Isn't it,
stuff.
I was gonna say, isn't it like 50-50? They have like
Mhm.
sports certified versus like the terminal doctorate kind of program, how they have
Yeah,
to
so they have to have 50%
actually.
have to have a terminal degree of
Yes,
some kind, whether that's an EDD, a DHS, or a PhD.
exactly. So for
Um,
anybody who doesn't know out there, not like a DPT, not the clinical doctorate, more in the
correct.
education realm of things.
Yes. Yep. And so that was the hard thing when I decided I was no longer pursuing it. It was kind of attached to my job.
Uh,
And
Makes
so I
sense.
ended up moving on to more of a non-clinical role while doing Luna PT in the background. And that's how I ended up where I am now.
And it's actually something I feel like I bring up to a lot of the PTs that we talk to, maybe some like yourself who are transitioning non-clinicals, like you can still work with Luna. Like it's such a great, like flexible
Yeah,
option to kind of keep up some of your clinical skills and work in a really nice, flexible one-on-one capacity and whatever kind of volume interests you.
absolutely. And I think we talked a little bit before we came on here, but like Luna reignited my passion for patient care, right? We all get burnt out when we're in our outpatient clinic, plugging
Mhm.
and chugging, seeing as many patients as we can, getting pressure when a patient cancels or no shows. And whether that's transportation related, it's usually in the neurologic population, it was that, or they were in the hospital, or so many factors can lead to a patient not coming in, not just because they don't want to. And so that's something I've really appreciated working with Luna is I've eliminated almost all of those barriers. I come to them. I had a patient that was 28, 5 years post-stroke, and they have aphasia, and their primary caregiver worked full time. And so she, was providing for her whole family. And so it was nice that I could come, even if the caregiver wasn't there, because she could communicate pretty well with me. And for high intensity gait training, we walked to the park when it was nice. And so that became almost our everyday thing was we walked from her house to her park once we got that in there, and she ended up doubling her gait speed after 12 weeks. So it's kind of fun to like be creative on what does high intensity gait training look like when you don't have a treadmill, you don't have a clinic, right?
Well, no, that makes it so much more functional for them too, right? When it's part of
Mhm.
the environment and their like world and daily life compared to a treadmill, which can have its purposes, but less,
Absolutely.
function.
It's so nice to like actually see the environment that patients working with because I feel like the home exercise program becomes more doable and applicable to their everyday life. So like I can truly tailor it to be like, okay, we're going to integrate your sit to stands into this. You're going to walk this many times a week with your parents. You're going to do this balance here in the kitchen, holding on to this thing, as opposed to like hoping they find the right environment to do it when you're translating it from outpatient to home.
So I wanted to dig a little bit more into your academia experience because that is kind of I mean, you hear about it a
Yeah,
lot, but there's not really a lot of clinicians actually have experience with that. So I guess any advice or like how did you work your way into the academia? I mean, you had a mentor, a colleague, you said, but I guess what other ways could someone who would be interested in that field or that type of
yeah,
setting, what would they do to do that?
absolutely. I think the biggest thing is looking for if you want to be a lab assistant, right? That's an easy way to kind of get your foot in the door. Looking, if you have colleagues from PT school or people you used to work with that have gone into academia. I mean, PT is so small, right? You have somebody you know somewhere that knows somebody. And so whether you go to CSM or other things like that and just become bumpable to people that are in your, whether you go to your state conference or things like that, and find somebody in your niche, in your specialty that like needs some help. Almost every program needs help in lab assisting because you have to have a certain number ratio to like professors or things like that to students so that there's enough hands-on experience for them. So that's a really good way to get your foot in the door for people to know who you are, or maybe you guest lecture. Maybe you're really good at vestibular, maybe you're really good at manual therapy, or you want to introduce pelvic to their curriculum, but they don't have anybody on their faculty that does that. Really great opportunity to be like, hey, can I come talk in your special populations class, whatever class you think applies to it? Or maybe you're really good at the shoulder and see if you can guest lecture in the shoulder lab or teach that to their, kines part of it, finding like what your niche is and finding what they need. And then over time, you get to know that faculty member and maybe you get to know the director. And then when the time comes, you're like, hey, I want to try to take that step. You have a little bit of experience to put on your resume.
That's awesome. Yeah. I mean, networking is so important, you just kind
Yeah.
of verified how important it is, even in the PT world. And, just, I think the conferences kind of stuck out to me because I don't go to a lot of those, but I feel like that's a great opportunity to meet people to kind of get your foot in the door. So appreciate that.
Yeah, I've been annoyingly involved since I was a student. Like I drank the
Yeah.
Kool-Aid when I was at PT school. I ended up on the APTA Student Assembly Board of Directors. So I think that has helped me get my foot in the door in a lot of places. Just not being afraid to talk to people. Anybody I've ever asked a question to, no matter how big their name is, always talk to me. Never had a problem with anybody in this profession wanting to share their knowledge. That's something I think is so cool. It's like you might have a name that you're like, oh my God, I idolize them, and you find them at a conference, they'll probably talk to you. It's really cool.
I'm totally with you on that too, because I feel like compared to some other health specialties, so like, I have friends and colleagues who are physicians and maybe they specialize in a certain area. I don't know how like buddy it is about sharing information with other like
Mhm.
competitors in the field, with other physicians who might have competing programs with them. I don't know if it's quite that like open conversation piece about things, but I agree. I think with physical therapists, I feel like we all want the patients to succeed and we want each other to succeed. And so I feel
Yeah.
like it's just a different dynamic, at least from what I've observed too.
Yeah. And I know that like trying to put together some local happy hours with other people you can just talk to is something that I know we're trying to do here in Chicago. So it's going to be really fun. So we could, just create a sense of community. Like, yes, we're all independent practitioners, but being able to bump ideas off each other or just know somebody else doing the same thing can be really powerful.
Chicago would be a great place to network. I feel like there's so much to do there that it'd be easy. There's some other places where maybe it's a little bit more difficult, but
Yeah, I
Yeah, I
feel like
mean, we're
if
everywhere.
you if you're really into becoming like really into staff or faculty, you have to kind of be open to moving anywhere. I've had some friends who've had to move like cross country or play other places just to kind of like get their name set. And then I feel like you maybe have more of an opportunity after that. But I feel like if that's your main goal is becoming faculty, you
Yeah.
probably have to be pretty open to beyond your like neighborhood kind of schools and stuff like that.
Yeah, I would agree with that. A lot of the opportunities there, I mean, there are PT schools opening all the time now. I feel like every time I look on like a job board, the APTA sends out their new jobs. There's like some other new DPT director role from a new thing that is establishing. So, looking out for those kind of things, if that's something you really want, or if you work in like a health system that's attached to a PT program, it's another great way to get into somewhere. And then like you can kind of start with just lab assisting and then you guest lecture, you become part of the course, and then over time, when things open up, you're more likely to get those jobs because they already know you. So I know if you're in a major metropolitan area, most of them have quite a few PT schools. And then more and more rural places I feel like are popping up because I know that's where PT schools are needed. It's like I grew up 4 hours west of Denver.
Wow.
And I think there's a new PT program in that small university where I grew up. because I know that's a needed thing. Besides that, there was like two PT schools in the whole state of Colorado. They're both in
Is that
Denver.
the Colorado Mesa one?
Yeah, that's where I'm from.
Okay, yep, I was gonna say I've seen that. Since I recruit for the Denver area, I'm very familiar with the
Yeah, I
Colorado.
grew up like 4 blocks from there. So I was too small for me to
Okay,
stay.
very cool.
Yeah.
Yeah, I think regarding academia, that's a pretty common thing, just across the board, no matter what kind of specialization people or what topic people are teaching in. I've heard this across many different areas. That you just have to be kind of flexible and be able to move, especially if you want a full-time professor position, if you want a tenure track type of position, you gotta just be flexible and look out. Although, like you were saying, some of those relationships and being part of a health system
Mhm.
can be a great way to stay in your local area.
Yeah. And there's, I think there's more and more becoming like tenure, non-tenure, and like there's, it's more secure in the non-tenure track than it used to be. Depending on there's like different requirements of certain things. So in one of my in my position, I wasn't tenure, and I was very okay with it. Like the requirements were very reasonable for promoting like 6 years later and things like that. So I think people have no idea because we're not academicians coming out of school, right? Like really truly
Yeah.
understanding tenure, non-tenure. It's all just like looking for the job that is the percentage of teaching, research, and service because they each have a different percentage. Just looking for like what fits versus trying to make yourself fit the shoe, I think is something a lot of people they're just trying to get in and then maybe are dissatisfied because it's not quite the role that they should be taking.
I think that's true in anything. People
Yeah,
just want
totally
a
agree.
job or something like that. And I try and tell new grads or anyone really looking for a job to really find something that fits them and not the other way. Do you think, I feel like there's a lot of people, a lot of great candidates that would look into teaching or would be great teachers or mentors, but the whole terminal degree situation, I feel
Mhm.
like yourself and me, limits that. Do you foresee as the need for PT grows that there might be less requirements on terminal degrees and things like that?
I kind of hope that they go towards that, right? Like, we're a clinical doctorate. And like truly what we need is clinicians. And maybe figuring out how, because like clinical research is obviously still needed in PT and almost having more of a clinician lens than some of it, right? So I think as keep growing, at some point we're just not going to have enough terminal degrees. They're going to have to kind of shift it. I don't think it's going to go down to like 25%, but I think so maybe go down to like 40 eventually, but I don't know how quick all of that's going to happen because it, as we become more of a research-based profession, we do need some of that rigor to understand all of that things, but I mean, our clinical knowledge is really good, right? And I know some of my favorite professors were like myself, they just had a PT specialty, like they didn't have an academic degree. And I learned so much from them because they had so much grassroots experience just treating patients. And I loved listening to their stories. So I'm hoping that over time that becomes as valuable, some of those academic degrees, because the ability to teach is also really important, not just having the research experience, because it doesn't always translate into good teaching.
Yeah.
I totally agree. Well, you mentioned kind of that clinical experience. I'd love to hear a little bit more about your neuro specialty and maybe some of the patient populations you saw a lot of, favorite treatment strategies, things that anybody across the board could maybe incorporate into their practice patterns.
Yeah, I love the spinal cord injury population, right? Not somebody we're going to treat a ton of at home. Maybe a little bit here and there, more that chronic, or if it's something you do a lot, you have access to them to get into. But spinal cord injury is so fun for me. I think that out of school, I was lucky that my neuro professor that taught me spinal cord injury worked at the Shepherd Center in Atlanta. And so she was just so good at breaking down what does Asia mean, all these different things, and like they're not breakable. I think so many people treat them, if you push them too hard, they're going to break. But there's like every other patient, you have to push them hard in order to do things. But it's just figuring out what function do you have left and how do we maximize that to get where you need to go. You know, having a lot of experience with it, being able to have the conversations of, we're not walking right now because we need to focus on getting you independent at wheelchair level, and then let's try standing. But like until you're independent, we got to get you to that place first. And then I had a really good time. I volunteer with our local wheelchair rugby team. And so like getting to see them and help them transition into having other people like them that they get to talk to and try things with and just be a part of a community where they're not just feeling breakable, like they feel just like they're normal around other people like them. In case you guys don't know, if anybody calls a wheelchair athlete or a person with disabilities, they call them inspirational. They hate that. Don't call them inspirational. They're just doing their thing. I know it's one way they just come to practice and they're like, somebody called me inspirational today. It was so cringy. So yeah, I just love working with patients with disabilities because they've taught me a lot and just being able to like, hey, I want to try this. You're like, cool, let's try it, right? No fancy gadgets, figuring out how to make that work for them, whether it's trying to go kayaking or all the different like random things. I just like to problem solve. And so in patients' houses, they're like, can we try a tub transfer? I'm like, yes, let's get in and out of the tub today. Can we do bed mobility? Absolutely. My treatment is just very, I, I like technology, but I actually prefer not to treat with it. I just want to be able to take the patient where they're at and like problem solve how to make their life functional. I'm a very functional therapist, I think is a good way to put it.
And I think that's the best way, just personally, because what's going to make the biggest impact in their life, right? It's the things that are functional, things that they're motivated and they want to learn how to do and get better with and be a more successful with. I agree with you fully on that.
Yeah. And I think it's like figuring out how to apply again, like high intensity gait training principles. How do you take it from, okay, we have to do it in a harness or with a treadmill? How do you do that without any of it? Right? So you can just be walking and pushing their pace. Well, if they can't walk faster, how do you make it harder? Let's put an ankle weight on them. Let's give a TheraBand behind, make them pull me. How do we get their heart rate up without having all of the gadgets? Because not everyone can have a harness. It is so nice when you have one because you can have your hands on more things. Or like it's so nice to have a Bioness or an Excite to really fire those muscles up. That neural priming is so important. But I think having the backup of how do you do that without the tools? Like I keep talking about this one patient I picked up, and I don't treat orthopedics, but it said hip, and it was on the wait list. And I was like, they're only 10 minutes from me. So I was like, fine, I'll pick them up. Ended up being a broken femur near the hip, and they have parasupernuclear palsy. So they have a Parkinsonism and they can hardly talk. So it ends up, I picked up a hip patient who ends up being a neurologic patient who was just hospitalized and has an IM nail. So they end up being my people. So a lot of those things have just shown me that like patient care is so much more than just the diagnosis we see when we pick them up. It's like we truly get to treat that whole person when we walk in that door. We are their gateway to making sure they get the things they need.
Yeah, and you being a Luna PT, Jillian, I'm sure you've had to use that creativity without equipment, right? Going to patient homes. So curious on if you found any tricks or like I'm sure you have tricks, but what are some like things that you've done in the home that you found to be really helpful for the neurologic population?
Yeah. One, I like to kind of like survey their house when I get there. I'm like, if they have, most of the time I want a caregiver there as much as I can. And like for my patient who has PSP, his wife is wonderful. He can really only say yes, no, and then he can write everything. So I get his permission to primarily talk to his wife first because he's fully cognitively intact. And then they gave me a tour of their house. He's not great at stairs, but they have his chair lift and like showing me where their problem areas were and then seeing what they already have. And then like if they need grab bars and actually doing a home safety evaluation is something that I don't think a lot of PTs think about. But now that we're in that home environment and a lot of our patients have fall risk in that geriatric population, like doing that survey. Hey, you need a tub transfer bench. Do you need grab bars? Is this a super unsafe rug or wires? Can we rearrange some
So
furniture?
many rugs everywhere. Like,
So that's usually I start with that after I like see what we're working with, and then if I like need extra help getting somebody up, which is not common, right? With Luna, we have pretty good safeguards on a lot of those things, but like you putting a towel, like a big like towel behind them and helping them stand up, so it gives me some more leverage. Or if they have a sheet behind them, like every patient has a towel or a sheet. You really utilize their walkers or relators if they have them and they need extra arm support and maybe their kitchen's not super accessible. Using stairs. So not necessarily like going all the way up, but using that first stair to do step ups versus like we don't have all those things and they can have handrails. With a lot of my balance patients, I try to find a free corner in a chair. So if they can have their back to the wall and they have walls on either side and a chair in front of them, they can really push their balance in a very safe way. And you teach them how to catch themselves. And so they can really actually improve their balance versus giving them super safe things that don't push the boundaries. So it's finding ways to challenge them while keeping them safe. All of those things are fun.
I mean, definitely a lot of creativity, and I'm sure you just open my like the towel and sheets, just a great easy thing. I always look for my gate belt, and some of them don't have it, and I'm like, well, we'll do it next time. And I feel like that's such
I
an
have
easy
a
thing
personal
to.
vendetta against gate belts. So
What?
like if you have a
What?
gate belt right here and you pull, like this is not the actual angle for where we pull up, right? It needs to be down by the hips. And if we're holding somebody up by their hips, that's not actually like the axis we stand on. So I'd rather have my hands like under the ischial tuberosities or like I'm holding onto their pants because that's actually going to give me leverage. We're not in the hospital, so I'm not worried about them not having pants. Like that's usually when I'd use gate belts the most because they didn't have pants on. But like, and then their caregiver, if they don't have a gate belt, what are they going to do? So really, if we can get them under the ischial tuberosities or at their hips and actually guide them, that's showing them the actual mechanics of the sit to stand versus if it's coming from the middle of their rib cage, you don't really stand up like that. So that's my personal vendetta. They're still needed. Please use them. But that's my own 2 cents.
Good point.
Some
Good point, though.
alternatives, right? Some good options.
I also hate hemi walkers.
Oh, mhm.
Oh,
I
yeah.
also don't like
They promote
rollovers.
disuse of the weak side.
They're so heavy too, right? Like,
They're huge, they're heavy, they don't promote, right? Because neuroplasticity, you want to use that side as much as possible. And if you're over here, you're never going to use your side. So those are my soapboxes as much as possible.
So I know, Jillian, you've been in this kind of non-clinical role, so academia and then non-clinical role, but like Joe and I, you moonlight with Luna. And sadly, you are leaving us non-clinically, but it's actually to go back to a clinical role, which I feel like is really rare, and lots of clinicians that I know are going non-clinical, maybe not looking in other specialties or other settings or things like that. So what's bringing you back to the clinic?
Yeah, being in various academic roles, sharing with the clinic, there was just some clunkiness, right, that made it hard to be the clinician I wanted to be, right? Whether it's insurance problems or push for productivity or just the guilt of your patients not showing up. That was just really hard for me to deal with, or whatever the requirements were. But treating with Luna and moonlighting has shown me, one, I'm still a pretty good clinician, right? My patients get better, they appreciate what I do, and it's just been really fun again. I haven't had this much fun as a clinician in a really long time. And so it gave me, I was like, I should be doing this again, like more full time because it's bringing me so much joy. Right. And so I didn't have that for a really long time. Like I haven't been a full-time clinician really since 2022. Because it burnt me out and I was like, I don't know, it's not bringing me this fire that I thought it was going to bring me. I did all of this training to not use it. I mean, I still use it a little, but not to the extent I thought. And so working with Luna, again, picking up that patient who had hip pain, but ended up being the patient who needed me, showed me that I need to show up for the patients who need me, and I love it again. So, whether while I'm leaving my non-clinical corporate role at Luna, I love this company. I feel like it's given me my fire for the profession back. I think it's a really cool place. It has a lot of really cool things on the horizon. I just think that my place is back in the clinic. So I'm going to go work an inpatient, outpatient mix at a cancer center. So that's going to be a fun, being able to dip my toes in. I love all the settings. And so it's always been hard for me to only have one setting. So I'm excited for that.
such a population of need too. I feel like sometimes, obviously, as they're undergoing cancer treatment, that is a priority, but the mobility aspects of things and making them functional in their environment, I feel like that's such a need. I'm so glad that they'll be having you, and sure, those patients are just so very lucky to have you there.
And it's exciting because I still get to moonlight with Luna, right? I can still keep my 4 sessions a week. And that's so doable on top of my other patient caseload. So it's nice that I can still dabble and the patients at home, and not have to have like the home health requirements. It's nice to have the freedom that we have, like we're an outpatient, but at home, so I can treat them as long as I need to treat them, not just until they are functional enough for somebody else.
Completely agree. Well, Julian, we so appreciate having you on today. I love your unique path. It's so cool to see the different steps you've taken throughout your career and just the amazing things you've done and will continue to do. So we just appreciate you being here, and we'd love to still have you on the Luna clinical side of things too. So I got you with us.
Thank you for having me and following my crazy journey that I've had. I hope that it helps somebody learn maybe what they need and they don't have to have quite all the steps I had.
It's definitely unique. So I really appreciate your time, Jillian.
Absolutely. You guys have a great day.
Thanks.
All right, we'll see you guys next time, next episode of Luna Unscripted. Thanks for joining us this time, and yeah, we'll be back next week.
Thank you for listening to Luna Unscripted.